There we go. All right. Good morning, you guys. All seriousness aside, we're going to talk science. That's me. And this is the garden of beautiful flowers of people that I work with, that I couldn't do this without. So all the science I'm going to show you is team science. These people come from all different walks of science, and we couldn't do it without them. And we couldn't do, this is going to be slow. Okay, we couldn't do it without our funders, by the way. Down here are all my grants currently. And we couldn't do it without our students and postdocs. So these people are Lisa's in Germany, Guillaume is now in Italy, spread all over the world. What I want to talk to you about is figuring out how I can see my own screen. Let me see if this works. Ugh, I hate this thing. I'm going to flatten it and I can't see anyone. So if you need to talk to me, just turn on your thing. All right. The road to outcomes. This is all about understanding behavior. So when you want to intervene on behavior, you first have to understand it. The road to outcomes is through precise specification of behavior and the determinants of behavior, what influences behavior, sometimes what causes it. Cause and influence are very different things, and we're going to be talking about that soon. So my case study for today is going to be obesity, because my background is in obesity research. And one of the things of almost any disease or uncomfortable state, because sometimes people aren't sick but just want to change something, have multi-causes. And obesity is like a chair. It's got many causes. Some of the main ones are stress, sleep, lack of exercise, and poor diet. So when you're intervening on something like obesity, first let me intervene on myself and turn on my timer. There we go. You have to choose which way you want to get in. I'm guessing a lot of this is 101 for all of you. You're pretty advanced, but I think we forget. I think we build these really complex interventions that don't really adequately address anything in the end, and maybe leave the most important thing out. So some of the guiding principles, when you start to develop an intervention, it's not something that you layer on top. It's when you have to, in this norming and storming process, storming and norming, it's when you get together with whatever team you're working with, and you lay out your preconceptions about how you think whatever it is works. So for our case today, obesity. And you will find that depending on the discipline, and even depending on the sub-discipline, people will think different things are important. And different things indeed influence different behaviors in different cultures at different developmental stages differently. So you got to make some choices. So what influences obesity-related behaviors? Those four legs of the chair: emotion, cognition. Those are very different. Don't let the cognitive mafia tell you that emotion is just a subset of cognition. It's not. Works very differently in the animal body. Personal characteristics, demographics, social environment, very important. The natural and built environment, macro scale social environment, so economy, socioeconomic science, policy decisions. You've seen how policy can affect our health in the worst writ large situation ever in the last few years. Your own behavior. So previous behavior, habits. Did you have breakfast this morning? If I didn't have breakfast this morning, I wouldn't be sitting here now. Your genetic makeup and your metabolic health influences behavior. So we've shown in girls, for instance, that the higher the insulin resistance, the less activity they get, and that it's a vicious cycle, but because that high insulin resistance makes them very sluggish. Allergies, obesity, all of this can influence your metabolic health. So the guiding principles is you've got to figure out where you're going to start. And then if you're working in behavior, you need some kind of theory, at least to start with. Now, we will talk about the shortcomings of all of our theories in a sec. But if you want a good overview of all the different theories, Susan Mickey's book is overwhelming, but really good. People have their pet theories. Many psychosocial theories have related, if not similar, if not exactly the same, variables, but people have been thinking about what it is. For instance, self-efficacy has been around forever. In Bandura's theory, people still talk about it and still use it. In self-determination theory, we call it competence or feelings of competence. These variables are often dovetailing, but you really have to think about what is the cause of behavior, what is the cause of the behavior that you're interested in, and what causes that cause. So how can you get at it? So let's say you want somebody to be able to take a walk. I'm going to get to this in a while. I will talk about this in a while, but how those variables work are dependent on each other. We'll get back to it, but this is a great book. Okay. Some key terms. I know it's Behavioral Theories 101, but I want y'all to have this in your head, and I want it all to be right there for you. Those are my dogs. They will be barking. So a theory is a formalized set of concepts. It organizes observations and inferences, and most importantly, your head and your team head, and is supposed to explain, pardon me, and predict behavior and outcomes. I emphasize supposed to. This is a conceptual model. Often our conceptual models are so big that we can't test them. Now, an empirical model, this one down here, is quantifiable, testable version of a theory. So what we want to do is get from whatever is floating around in your head up here and in the head of your teammates to land on some theory behind the behavior once you choose the behavior, and then to build a model of it so that you can actually test it. I hope I'm making sense, and if I'm not, there'll be time for questions afterwards, or you can just type it. Not you guys, no questions from the dogs. So behavioral theory 101. Construct is a hypothetical explanatory concept which is not directly observable. For instance, intelligence, motivation, fear, anger. A variable is what we measure. Some are immediately observable. So age is a variable. It's not a construct, really. Height, a variable. Hours spent watching TV, a variable. Some are constructs made measurable using operational definitions. So Cohen's stress scale is an operational definition of stress. If it really captures stress as we mean it, who knows? Your cortisol levels, an operational definition of stress. Does it really capture stress as we mean it? Who knows? Do those things dovetail? Maybe. Really important is thinking about mechanism of action. What mediates the effect of the intervention on the behavioral outcome? I guess if you're looking at it this way, intervention, behavioral outcome. These can be specified in terms of changes to capability, opportunity, motivation, or other behavior. So what's the mechanism of action that's between the determinant and the behavior? And that's the thing you're aiming at, tilting those mechanisms of action. So let's talk about the theories that we have now. So all of these theories in Susan Mickey's exhaustive and exhausting book, which is wonderful. Let's talk about our psychosocial theories just for a hot sec. This is my pet theory, the self-determination theory. And it says very simplistically, because I could give hours of lectures on just this theory, but I won't. It says that relatedness, so feeling related to people, autonomy, feeling you have some control over your own life and behavior, and support, social support, and also other supports, sometimes called autonomy support, lead to perceived competence and a higher ability to self-regulate your own behavior. And these lead to feeling more motivated for whatever behavior. And this leads to behavior change. It's a good theory. What's wrong with this theory? Oh, it's a one-way ticket from A to B. And I don't know about you guys, but that is not how my behavior works. That's not how I work. In fact, let's talk about me, favorite subject. The target variable might be chocolate consumption. I love chocolate, dark chocolate. And let's say my desire to eat chocolate changes over the time of day. So if you think of this axis as not so much desire, this axis lots of desire, and here we have morning, afternoon, evening. Here in the evening, I'm like, I could take it or leave it. But let's add proximity to chocolate to the variables. Okay, and so my desire for chocolate and my proximity to chocolate shifts throughout the day. Yeah. So you could see at this particular evening, not only do I want chocolate, but it's right here on the table next to me. And what's going to happen, you guys? Am I going to eat chocolate? Let me hear the rousing. Heck yes, I'm going to eat chocolate. All right, let's add another variable. Let's add stress. My, at least, ability to stay away from chocolate is definitely influenced by stress. The more stress, the more chocolate. Would you agree? All right, so all of these variables vary throughout the day, okay? This particular evening, I don't care so much about chocolate, but I'm a little bit stressed and chocolate is right near me, not that far. I don't have to go to the next room. I don't know. Am I going to eat chocolate? It's a toss-up. I might. Let's add another variable. Let's add my friend Darcy. Darcy also loves chocolate. She's worse than I am. Now, this evening, I'm really feeling like chocolate. Chocolate's close. I might have to go into the next room for it, but it's not that far away. I have it in the house. I'm also feeling fairly stressed. So I'm doing my best not to eat the chocolate. I'm really wanting her. And then Darcy comes over. I'm shot. That's it, you guys. I'm definitely going to eat chocolate. So what you see here is that behavior is influenced by any number of things. Some influences are stronger than others. So Darcy coming over, boy, if I'd had to go I probably would have gone to the store for chocolate by then. So, and it's dynamic throughout the day. So these linear models don't serve us well in a dynamic world, but they do represent decades, if not centuries, of research. And we shouldn't throw the baby out with the bathwater. We just have to repurpose them. There are some new guiding principles in this world, and it's this gen sensing. We've got the Internet of Things, which gives us sensors for on body, for instance, the continuous glucose monitor, chemical sensors, particulate matter. Right now, we're putting sensors on a panel that they wear that senses particulate matter wherever they go. The ingestible implantable sensors like the Proteus pill. Deployable sensors that can be put on various street corners that could tell us about traffic without us having to carry the sensor around. All of these new sensors and have this persistent user interface. So we can get from our phone, which are never far away, voice traces. We can also we can ask people questions called ecological momentary assessment. We'll talk about that more, EMA. All of these sensors are connected to smartphones, to watches, to base stations. They all speak to one another in smart homes. My home is smarter than I actually realize it, and more things are speaking to one another that I want to know. And all the data we used to get, for instance, annual checkups. So we've still got all the old data that moves much more slowly in time. It's just that now we can start to use it differently. And we've also got our digital breadcrumbs. So my husband bought a shirt at this new camping place. And on my Facebook page, that camping place shows up with an advertisement for Father's Day. Mm-hmm. So our digital breadcrumbs are everywhere on the internet, and they say a lot about us. All of this data that we're getting on ourselves and on each other are provided from various sources, including not just the doctor anymore, not just the EMR, electronic medical records, or which didn't used to be electronic, but also patient-facing technologies. So, for instance, my Fitbit or the Apple Watch. All of this goes now. When I go to my doctor, he wants to see my Fitbit dashboard. He doesn't hold my phone. He just asks to see my Fitbit dashboard. Also, he asks to see my scale dashboard because I weigh myself on a scale that puts it right in my phone. He doesn't weigh me anymore. He lets me weigh myself. This all allows us to dynamically detect, anticipate, understand, and intervene on behavior. This continuous behavioral and physiological monitoring is revolutionizing the way that we think about the behavior and the way that we can change it. And then we've got these data hungry and ubiquitous technologies. The smartphone hooked up to the smartwatch gives us all of this data: ambient light, proximity, where you are, cameras, accelerometry, gyroscopes, GPS, microphones, compass, apps, phone, email, text. It's right there: internet, social network, who you talk to, and real-time data transfer. It's mind-boggling. And it's mind-boggling to try and use this data. Don't underestimate it. And a lot of you know this. Okay, mobile health. What we're working on here, mobile health, is research, observation, and intervention that can monitor, model, modify, and maintain the 4 M's, health and health-related behavior, in real or near or just in time, we'll talk about that, and provide dynamic, personalized, and responsive interventions, and in context. This is the clincher, you guys. Check your dogs and your assumptions at the door. Context is key. So there's some wonderful articles. The author is escaping me right now on how, but I'll get it to you, on how no matter how good, and I've seen this is what drove me to mobile health to begin with. You give a great intervention, you bring people in, we brought kids into, we did this fantastic intervention on obesity. We helped them shop, we gave them money, we took them to the markets and showed them, to their own markets and showed them healthier alternatives. And after the intervention, as in most of these kind of interventions, that is not happening in their own environment, when they go back, it's recidivism, just like drug addicts. You go back into your environment, you go back into your own context, and the intervention effects wear off. Whereas if you intervene in context, you got a much better chance. Okay, so what we've got here is a data storm that can provide support that lives up to real life. So we want to understand and intervene, provide just-in-time support, and adapt this as we go to the changing needs of the environment and the person. We want to adapt to address conditions that are likely to occur rapidly, unexpectedly. We want to be able to be there for a person when they're vulnerable, so when they need us, or when they have the opportunity to listen to us. So for instance, if I am having anger management problems and I'm about to go in to talk to my boss and it's going to be high stakes, now is not the time to intervene on my stress. I don't know exactly what the right time is. We don't know that yet. Often we don't know when the right time is, but I'm not open to it at a moment like that. So maybe in the morning before, or who knows, but we need to intervene when people need us and in the person's natural environment. Now, you see those numbers, 1, just in time. What is just in time? Just in time, mind you, is not all the time. Is it now? Is it when needed? Is it when anticipated? When we anticipate something coming up? When the person's available? When whatever it is happens? Before it happens? We're not sure. And Just-in-time adaptive interventions support who? Who do they support? Often researchers, clinicians, patients, participants. It's all stuff you have to think about as you build these interventions. So here's some key terms. A dynamic model takes into account momentary and longitudinal changes in constructs, relationships between constructs, within-person fluctuations, and the influence of shifting contexts on all of these. That's a lot, but I'm gonna parse it out for you. This is just a pretty model that Daniel Rivera made, and I love it. It's a dynamic behavioral model based on social cognitive theory. And it's a fluid analogy that shows how, as your self-efficacy, for instance, your feeling of competence or ability to do a thing, as that gets higher, that's this little tank here, fluid analogy. So that's why these are called tanks. As that gets higher, that flows over into other things, and it flows over, for instance, into behavior. And there's a tipping point when it flows over. But I just wanted to show you this because it's so pretty. I'm going to move on. So all of this is talking about how to define your research question. You can induce. You can begin by saying, we want to change emotion recognition because we know it's related to dysregulated eating, and that's related to obesity. You can start there, or you can deduce. You can begin here. You can say, we want world peace. We know that world peace is affected by aggression, so maybe we should start with mindful spaces. And it's really a good exercise to sit down with your team and say, where are we beginning? I reverently borrowed this from Bonnie, our next speaker, who now has to find another picture, but she said it was okay. And when you're deciding on your research question, you really need to think about what's the larger framework and where you can make a dent. Because the ecological intervention framework is really overwhelming. There's a lot. Are you going to intervene on policies? On the social system? Just on the individual? If you're going to intervene on the individual, what are you going to intervene on? Knowledge, skills, motivation, habits. Here's what you could do for the social system, what you can do for the environment, and here are all the behaviors that it affects. And here are some of the bad outcomes. There are also good outcomes. So when it's good to sketch this out related to whatever behavior you are going to intervene on or whatever outcome you're interested in, to sketch this out and make some really informed choices depending on the expertise in your group. Then you got to choose your population and location. I can't begin to tell you how important this is. Who are you going to intervene on? How old? Kids, and I've worked in kids and families all my career. And now I'm working with a group that works in aging, and it's a whole different bag of peas. What people can and can't understand, what they do and don't know. And that changes by culture, religion, abilities, what the community is like, what kind of family they're embedded in. So what's your population? Define it very carefully. And then where are you going to intervene? So that could be, I'm going to intervene, in rural or urban parks, or in homes and restaurants, or in schools, or it could be, I'm going to intervene in India. So, and then you still have to make these choices. In our intervention in India, we were going to intervene in Christian religious institutions, and that turned out to be very complicated and stupid. So, of course, we broadened that out. This was back in the day when I was a young girl. And even then, a religious institution to us meant something entirely different to the populations we were working in. So all of this very important. If you're working in a population that's outside your ken, be sure to have community partners and that know what they're talking about in that population. So quick key questions: what and who? What are the specific health outcomes of interest? Oh, hey, look, I'm going to use obesity as an example. Which population are you going to study? Behaviors and determinants of those behaviors differ across populations. I can't emphasize this enough. And I can't tell you how many times I've seen researchers, including myself, get in their own way because they think they know. But behaviors and determinants of behaviors are really strongly influenced by culture and country. So that will say that there are many people in the United States that are from other cultures, even if they were born here, their home cultures are different. And then the country, the United States as a whole, lays over a whole new layer. So for instance, the kids that I was working with most recently come from Hispanic background, from Mexican mostly background, and South American, and they're second generation or first generation United States, so they eat for two cultures often. They eat the home food, and then they eat French fries and whatever is very much the American food. All something to think about. So socioeconomic status is very important, as you've seen in the last few years. Urban versus rural, age, cognitive development, health status, all of these things matter. And when you're narrowing down a population you want to work with, you need to think about this. And which behaviors are related to the chosen outcome? Now, I've said this already, but choose your battles. Where possible, make this evidence-based. And when I say choose your battles, I mean you can't do all of this in one intervention. It's ill-advised. Let's talk about transdisciplinary research for a hot sec. So let's say we've decided to intervene on diet. And this comes from an actual project that I'm going to show you in a minute. And because you are working in mobile health, you are going to be working with teams of people from different disciplines. And we decided to work on eating behavior, specifically actual eating behavior, not what you're eating, but when. And so we were using sensors to detect eating behaviors. And it turned out we were having this terrible misunderstanding that we didn't really know about until we started to try and analyze the data. Engineering student, what are we measuring? A bite. Engineer number one says, no, this is a meal. Behaviorists 1 and 2 are saying, what is a meal? What do you mean meal? An engineer from another team says, that's not a bite, that's a chew. Behaviorist 1 says, that looks like a hand motion to me. Engineer X measures chew with a sensor on the jaw. Engineer 2, how about eating event? Behaviorist 1 and 2, how would you define an eating event? And this went on for a long time until we could actually figure out what it is that we're exactly measuring and come to a terminology that made sense to behaviorists and engineers. So often when you're working in a transdisciplinary team, you've got this problem. Everybody sees the elephant differently. And you really, during your norming and storming periods, you all have to figure out how you're seeing this elephant. And it's really a lot better to do it at the beginning of the research than to find out halfway through that you're all looking at a different elephant. A really good example, and what came out of that discussion that I showed you of it's a bite, it's an eating event, is Brooke Bell, who just got her PhD, Dr. Bell, did this wonderful review of 32 sensing studies of just of eating. And we could not do the kind of review that we wanted to do because there was no agreement on terminology. So in the category that she finally made of eating occurrences, dietary events, drinking activity, eating activity, eating episode duration, eating episodes, eating events, all of these things, that's what they called them. But in the end, we didn't know what was packed into that often. So this makes it very, very difficult in the field because indeed we are using all sorts of different sensors to try and describe the same or similar behaviors. So we have to be very clear about what it is that we're describing. We thought we were measuring bites, hand to mouth, as behaviorists, but it turned out that the engineers used bites and decided that, because their algorithms were 85 to 87% accurate, not every bite that they detected was a true positive, and they also had false negatives. So they decided when they have 10 in a row in a certain amount of time, we're going to call that eating, or we're going to call that, in the end, we called it an eating event. But we couldn't use the bites as data. I hope I'm making sense. I can't see the chat, so unmute yourself if you need a thing. So key questions here are the deeper what. Which determinants are related to these behaviors? Make it as evidence-based as you can, even though there's not a lot of evidence yet in mobile health. And also think it through with each other. What makes conceptual sense to you? That how does behavior work? Because we're in a new period of time where behavior is being unpacked in a new way because we can monitor it in real time. Which, what, when, how, where, these are key questions. Pare it down. Which constructs do you really need to get at? Which behaviors do you really need? You can't have them all. Which outcomes do you want to intervene on and thus measure? And then how are you going to measure them? This is a transdisciplinary collaboration, just like the bite thing. You decide how you're going to measure what you're getting after and make sure you all call it the same thing and understand it. What timing, what frequency, and what context of measurement? These are hard questions. We don't know yet how frequent we have to measure something because we don't know how quickly or slowly things change, right? So there's the Nyquist principle that says that if you have to measure it like 100 times more often than a thing actually changes. I'm paraphrasing. I have this not particularly right. Somebody can pipe up. To understand finally how a thing changes, and to understand in the end how the parsimony of when you actually have to measure timing and how frequently you have to measure. We don't know how fast mood changes. I mean, I have an idea that that's pretty ephemeral and can change pretty quickly, whereas my self-efficacy to walk, let's say, might not change so quickly, but we don't really know, do we? Mm-hmm. And what's the context of a measurement? When do where in what situation do I really need to measure things? And how does that color how the gold standard measures are seen? For instance, let me give you this one. How am I doing on time? Oh, I'm never going to make it. Let me give you this one. Let's say I'm a new mother and I've taken my child to the daycare center for the first time and I'm going to pick her up and I'm late. I get pulled over and the cop takes my blood pressure. What is the correct blood pressure then? Is he going to immediately take me to the hospital because it's too high? We don't know. We only know what your blood pressure is supposed to look like when you go to the doctors, or now sometimes with a blood pressure cuff at home, but we don't really know, right? Which technologies to use? We don't know that often a lot right now either. There are many choices. Where can you measure things ubiquitously? So, like with sensing, because we've all got these, magic and warm fuzzies about sensing, but there are some things you can't measure ubiquitously. Sometimes you just have to ask. And when is that? And where is that? You can't yet measure a tummy ache. You can't yet measure a headache. And my 2 cents is you can't measure my stress. You can approximate it, but I don't think you can actually get at my experience of it without asking me. Do we have validated measures? The problem with validated measures and new technologies is The validated measures weren't made often with the new technologies. So do they work with them? We don't know. And what's good enough? So is a Fitbit is not really good enough to get between person data on physical activity, but within person, it's just fine. I can see, you know, if we're just talking about me. So, and what are the roles of more traditional measures in this new world? Okay. New technologies aren't magic. Technology can add to fundamental knowledge on behavior and vice versa, but if you don't have any kind of good research design and theory behind it, otherwise we just have toys. Theories and models drive which behaviors to measure. Make sure they're explicit. Help with best measures, you need it, and understand the mechanisms of change. Very important. And you need expertise in specific populations. Okay, engagement. This is a sidebar, but we really need to maintain engagement. How do we do that? You need somebody on your team with at least some kind of HCI expertise. It can, you know, people are used to very slick things. Your technology can't be clunky or ugly, because in the end, people aren't going to wear it or use it. So you need expertise in targeting and tailoring. You need, I think, participatory design, which will be talked about by the HCI people, which is when the people that you are serving actually help you design the thing you're going to give them. You need to motivate people to give you their data. There needs to be trust. Oh, that's that. And then the other thing that I wanted to talk to you about is how difficult this data is to use. Don't underestimate it. So the nature of the measure, it can be objective or self-report. We can infer direct from observed eating or indirectly. It can be continuous or infrequent. That's my duck. It can be precise or inaccurate. It can change quickly or slowly, these measures. The trajectory of change can be linear or loopy or full of dogs. And all of this has reciprocal influences. And then on top of that, there's missingness. So this data, okay, let me find my slides again. Here we go. So I wanted to show you this monitoring and modeling family eating dynamics. This is an NSF funded grant. And this is, I will go through this really quickly. This is the intro where I talk about how measuring dietary intake, what you eat, is the wicked problem in obesity. We've got EMA, we've got sensors, we've got, you know, the refrigerator that watches you, but it is the wicked problem in obesity research. We can ask people, we can observe people, we can sense people, we can get biological data, we can grab small data, but the bottom line is we don't know exactly what people eat because A, they don't know, we can't measure it, and they don't want to tell us. It is a total rabbit hole. With me? So person is a complex system embedded within a complex systems. Thank you, Richard Conroy, for telling us all what the true Nyquist situation was. This is all about system science, which I will also skip, but just you are a system within another system. And all these systems interact with one another. So we decided, instead of dealing with eating, what people are eating, because we don't know. And I've been down that. I've been down there with 24-hour recalls and observation and sensors and you name it. We decided to look at family eating dynamics because family eating dynamics have been shown to influence eating behaviors in a positive or negative way. And it's also been shown that it can be changed through interventions that impact weight. But until recently, family eating dynamics could only be measured through interviews, questionnaires, or observations. And enter FED. This is our systems map that if mom is in a bad mood and gets angry at child one, that child one will get angry and eat faster, that how this all influences one another. So we put together this M2 FED cyber physical system. And it had smartwatches and smartphones and microphones spread out through the house, beacons that could tell you, that attached to the smartwatches and told you who was who, and ecological momentary assessment. And we installed these in family homes for 2 weeks. It was intense. And we measured ubiquitously all of these things. And then we had these, these EMAs. So we had EMAs that were just stress and mood, and we had EMAs, so ecological momentary assessment questions answered on the phone, that were triggered by these eating events that we were measuring with the watch. Here is the whole fancy scheme about what we asked people. And here is the whole fancy scheme about what we thought might happen. This was our theory. And we were trying to define bendy places where we could intervene. So this is a reconnaissance project, trying to find out where bad things happen and how we can intervene, how we might be able to intervene on that. What we wanted to know about eating were all of these things. So to the woman who asked me, how can you just intervene on one thing? Because you have to know so much about it. It's a good place to start, at least. And we got all this data, and what are the new questions that we can ask? Where are the useful signals in all this current noise? I think this is the slide I wanted to get to. So we want to get to these multidimensional generalization spaces, or state spaces, representation of behavior, where the probability of behavior, let's say eating in the absence of hunger, is, and this might be self-regulatory skills, high or low. This might be self-efficacy to, I know I can stay away from chocolate. It might be environment. And what you think about is that the actual probability of behavior changes dynamically depending on all of these, but there's not a magic point for them. So let's say if my self-regulatory skills are really high that day, even if I'm not so sure I can stay away from chocolate, if I'm feeling strong self-regulatory, then I might, my probability for, jumping over to chocolate might be lower. So I always say, this, you think of this blanket, think of this as a small animal crawling around under the blanket, and how all these variables